Yes, Kumar.
Good afternoon, and thank you very much for this opportunity. I'm going to talk about, can I have my slides? Yeah. IOL power calculations in very short and long eyes. With today's era, this is the data that we had. So this is modern cataract surgery. They all want perfection. We also want perfections. Patients' expectations have increased, and doctors' expectation and delivery to be giving good results has also improved over the number of years. So there was a old study done by Warren Hill where he said that about 78% of the ophthalmologists can get a target of 0.5, 6% of surgeons got 84% and better, and 1% of surgeons got 92% or better with the older formulas that were being used. So 95% of your patients are very good in the axial length of 22 to 24.5, but beyond this and ahead of that, so before and ahead, 2.5%, 2.5%, which are the outliers where the results were a big question mark. So it is said a crime is just like a jigsaw puzzle. To solve it, you need to have a jig and, of course, have a saw, right? So this we need to have both. So we need a combination of accurate biometry and an accurate formula, without saying that, of course, you need to have a perfect surgery. So accurate biometry itself has come a long way over the number of years that it has improved. We have ultrasonic biometry, we have optical biometry, and interop aberrometry. Ultrasonic biometry, I personally am of the opinion it should only be immersion. You do not do contact biometry at all. And there's no also doubt that optical biometry is better than ultrasonic biometry. The error caused by 1 millimeter of compression by mistake, it can give an average error of 2.5. In long eyes, if you give an error of 1.75, and in short eyes, it will give an error of 3.75. So this is an error that can happen. A good scan, we all know this, in immersion, you can have a good scan, but a bad scan, you'll have wrong echoes at the wrong place, and that's not going to give a good result. As far as optical biometry, you have a huge list of instruments that are available. We have IOL Master 500, 700, Lensstar, Aladdin from Topcon, Galileo 6 from Zimmer. We have iStar 900, and now I'm using the Antirion. I also have a Lensstar, but Antirion personally I feel is phenomenal. A, because it's an anterior segment OCT as well as optical biometry, topographer, aberrometer, all included in one. So this gives a big advantage in comparing different results that are there. I just want to show the first slide. Where does the error actually come from? So this is what has been also documented, that corneal keratometry results in 27% of the errors that are coming out of results. IOL misalignment is 14.5, IOL tilt is 11.3, and angle kappa is 7.5. So this is where the errors are coming from. Of course, we know that IOL tilt can only be measured on eye trace, and no other machine can actually measure an IOL tilt. Now coming to swab source OCT, this is much better because it measures keratometry more accurately. Axial length, central corneal thickness, anterior chamber depth. Lens thickness is very, very important because it can tell you predicted lens placement, one, and two, EPL can be much better out of this. It'll also give you a white to white and much more higher accuracy. Foveal fixation is there or not, you'll come to know if there's a posterior staphyloma and poor fixation. There are also now new biometers actually give you a spot, and you can increase the intensity of the spot. You can also put in refractive error so that all these defects which are happening in the older optical biometers are not there in the newer optical biometers. Measurements possible in eyes with dense cataracts, which was not possible before, so media opacities, and big advantage is that it measures the anterior and posterior corneal curvature at the same time and gives you total keratometry, which is more relevant in calculation. So now the question comes to which IOL formula to really use when. Over the number of years, we had the SRK-T, SRK-1 and 1-2, and then all the other formulas which were originally being used. But you can see here that Holiday 1, half a Q, all depends on the axial length. And reasonably good studies have been conducted where there is now the new induction formulas is ray tracing. So there is an Olsen and Oculix, which is there in some of the biometers, which helps you to do this. We also have the Hill RBF, where you feed in all the data, it gives you data back. So it's like artificial intelligence, and this gives a big advantage over the older formulas which were there. Conventional teaching says that average eyes of 22 to 24.5, Holiday 1. Short eyes, you use half a Q. Medium to long eyes is better to use Holiday 1. And extreme long eyes, one can use SRK-T. But over the number of years, this has again changed because we know that now small eyes have shallow anterior chambers, long eyes have deeper anterior chamber. And it's true that these percentage of cases where the most of the errors really happen. How does anterior segment size actually vary and this will result in a wrong EPL calculation, and that's the reason why these errors happen. So you can see that if you have a large megalocornea, large axial length, the megalocornea and large bulb all of this will result in a different axial length measurement, and you will get an error in that level. So optical biometers do tend to measure axial length higher than what it actually is in an axial length of more than 24.5. Hence, in more accurate results, then came the varying catch axial length modification, which got further improved, and this got incorporated, and this gave much more better results. And that actually helped in getting much more accurate results in smaller, shorter eyes. Small errors in the measurement of much greater impact on short eyes, and that's the reason why the lens, much more powerful eye has to be used. Short eyes susceptible to small variations in effective lens position. Typical errors in such eyes are unexpectedly in myopia outcomes, as the IOL ends up sitting little more anteriorly. So if you have a smaller hyperopic eye, a high hyperopia, the lens may sit more anteriorly, and that may result in error. Over the number of years, all the formulas have worked out, but just to conclude that a Barrett Universal 2 has given the best results till now. With the application of the Warren-Koch axial length modification, will help you in hyperopic and myopic outcomes in long eyes. Barrett also said that the least prediction, so you can see that Barrett and Olsen are doing the best for long eyes. This also is proven. And another thing is, if you have a long eye, then Haigis also does very well. And if you have a post-op refractive eye, then the Haigis L also does very well. This is just over the number of years, the things have improved. But you can see that Barrett 2 is covering reasonably everything that you nearly need in today's work. To summarize, it's an extremely long or short eye in modern formula. The Barrett Universal 2, Hill RBF, Olsen, and Holiday 2 work very, very well. Additionally, some studies have shown that the Haigis is more optimized with an axial length of less than 22 and ACD more. And one more thing is that if the eyes are with axial length more than 25 mm, Holiday 1 also works well with the adjustment from the Warren-Koch that has to be applied to that. Steps to optimize outcomes with extremely long and short eyes. This is your lens constant. Validate your measurements. Do not move from the process. And keep checking and keep making sure that you see the post-ops yourself to really know what is the outcome of the result. I'll show a small video. I'll just show one part of the video. This was, I think, first time we ever implanted.
Small eyes can be classified according to anterior chamber depth and axial length. This video will demonstrate the challenges found in two cases: extremely short axial length and a small ACD, namely the nan-ophthalmos and micro-ophthalmos with an iris coloboma. A unique complex case, a software engineer by profession with high hyperopia was referred for refractive correction. On examination, her best corrected visual acuity was 20 by 40 part in both eyes with a correction of plus 12 diopters. On slit lamp examination, she had a normal sized cornea and a very shallow anterior chamber, and gonioscopy showed occludable angles with a normal IOP. She underwent a prophylactic YAG-PI in both eyes. Her dilated fundus examination revealed heaped up optic nerve head and...
So what I'm trying to say here is we went ahead and did a clear lens extraction for this girl. But if you see...
CD of 2.68 and her lens thickness of 4.27.
So we have a white to white of 10.7, ACD of 2.68, and a lens thickness is 1/4 the actual size of the whole eye. So we know that we are dealing with a nan-ophthalmic eye with a IOL master of 14.85, an AL scan, which I had a NIDEC AL scan that time, 14.83, and a keratometry of 54 and 57. You try to put this data in many formulas, it will just tell you out of normal reach, and won't let you calculate. We still went ahead and did calculations. Hoffer Q said 65 and Holiday said 48.5. So the question was what to really implant. I decided to put a 65 diopter. This was a choroidal scleral thickening of 2.3. So it was an extremely small eye, like a nan-ophthalmic eye. We didn't know really what to do, but then we got a lens manufactured personally, and we decided to do a clear lens extraction for this patient. And there are challenges which all the precautions are taken because you're dealing with an eye. I did not make any nick on the sclera, which some doctors do, but with all the modern things, like putting the rest of it, I went ahead and did femto. The reason I did femto was my rhexis would be ready. That was one big advantage here.
Rexis and a 4-quadrant division of lens performed. A 0.75 millimeter side port incision made and a gentle release of the aqueous, replaced by an OVD. Using a micro-Rexis forceps, the CCC was grasped out.
I didn't do hydro.
Bimanual IA
straight did bimanual IA.
The lens material. Globe not allowed to collapse because of the use of the OVD. Main incision of 3.4 millimeter made. 65 diopter, highest ever IOL manufactured, was loaded, placed in the cartridge and then injected. Loaded the hydrophilic IOL. Significant amount of pressure needed to push the 1.9 millimeter thick IOL through a 3.4 millimeter cartridge. Precaution taken to not let the globe collapse. IOL placed in the bag and the trailing haptic dialed into the bag. Suture placed, bimanual IA done for OVD removal. Air placed. Post-operatively, overwhelmed to see the first day post-operative visual acuity of 20 by 60 and a refractive error of -1.5 spherical with a -1.75 cylinder at 20.
So this was the smallest eye I've ever operated, and I got a brilliant result. So of course God was with me at many steps of surgery and the calculation. Well, this is what I've attempted and reasonably succeeded quite well. Thank you for your attention.